Hello, my name is Kim Vuong. I'm a current medical student at UNC Chapel Hill. I'm in my 4th year going into pediatrics and hopefully pediatric nephrology. And the project that I chose was actually part of my master's paper project because I just finished my MPH at UNC School for Global Public Health. So the project is about pediatric nephrology and kind of the co-management strategies and what we're doing to empower our primary care providers to manage certain nephrologic conditions. And the motivation behind this really came from, well, first, primarily my interest in pediatric nephrology, but also because over the last 10 to 20 years, chronic kidney disease has kind of been more on the rise. The incidence in the adult population from 2000 to 2008 has actually doubled. And a lot of that has to do with diseases that put patients at greater risk, like hypertension and diabetes, that has also been on the rise. And so actually what ended up happening is when Healthy People 2020 got released by the Department of Health and Human Services, one of their goals was actually to reduce new cases of CKD, as well as reducing complications, disability, death, and economic costs associated with that. While the motivation for the Healthy People 2020 was really based on adult level data, in the pediatric kidney world, we kind of were riding that wave in hopes of also improving access and goals for our pediatric patients. And as with a lot of things in the pediatric world, a lot of times we have missing data points. So a lot of what we know and understand about disease processes in the pediatric patient population is based on information from the adult world. And in terms of trending data, we don't have a good estimate for the true prevalence of CKD or chronic kidney disease in the pediatric population from either a local or North Carolina-based data or even nationally. What we do know is the rates of end-stage kidney disease, or ESKD. In the United States from 2009 to 2011, the incidence was 15 cases per million children, and the prevalence was 87. And based on these estimates, the CDC thinks that by 2020, we'll have 8,000 children who classify as having end-stage kidney disease. And based on national rankings, North Carolina is unfortunately the 10th highest state in terms of prevalence. We actually contribute 3.4% of the national cases of pediatric end-stage kidney disease, and we account for 2.6% of kidney transplants in the US. The most recent data I could find was in 2005, when we had 407 children who had held a diagnosis of end-stage kidney disease here in North Carolina. Looking at cost, in North Carolina, chronic kidney disease care averages out about $55,000 per child per year, and end-stage kidney disease cost really varies a lot based on the need of the specific patient, but dialysis can be around $100,000 per child per year. Different medication costs also vary. And in 2006, North Carolina Public Insurance for Children spent more than $8 million on end-stage kidney disease care. And one of the big things that we wanted to highlight is the difference between pediatric nephrology care and adult nephrology care. While pediatric end-stage kidney disease actually only accounts for 1% of the national prevalence of end-stage kidney disease, the care for these patients is very different. Part of it has to do with the etiology or the cause of the end-stage kidney disease. It's very different from the adult population, because in the pediatric world, of course, there's more congenital issues or polycystic kidneys that just happen to present at an earlier stage, whereas in the adult population, it's usually hypertension or diabetes. And some of the other important aspects of chronic kidney disease management in pediatrics is just a lot of the downstream or long-term effects that we can see. So in these patients, they can have a lot of psychosocial issues, either personally or just due to family dynamics. You also are worried about changes in nutrition or any things that could alter their growth and eventual development, either psychologically or even physically, and they have higher rates of mortality. So with these kids, if they don't have the appropriate care or they just have really bad prognosis based on their disease, they can progress to end-stage renal disease or end-stage kidney disease, which will require either chronic dialysis or transplant. And a lot of these kids, as our management gets better and better, will just continue to have chronic kidney disease into adulthood. So unfortunately, while the rate of chronic kidney disease in the pediatric population has been increasing, it looks like the workforce just isn't there to support it in terms of making sure that there are enough pediatric specialists or nephrologists to take care of these patients. Almost 50% of general pediatricians have reported that they don't think there are sufficient numbers of pediatric nephrologists to meet the needs for their patients. The average wait time nationally is 6.7 weeks, and the last I heard at UNC, it's actually 3 to 4 weeks. And 16% of pediatric patients travel more than 80 miles to reach a pediatric nephrologist. The AAP, or the American Academy of Pediatrics, was actually really concerned about this specialty shortage and did a survey back in, I believe, 2014 or 2010. And what they found is it's an issue of both supply and demand. We've talked a little bit about the demand side with higher rates of CKD among pediatric patients. We're also seeing things like childhood obesity, which is of course on the rise, and all the complications associated with that, which kind of has transitioned these patients into having more comorbidities at an earlier age. We've also gotten a lot better in the way that we're able to care for kids with congenital kidney diseases, which means that they're surviving into later and later stages of life, and we just don't seem to have the providers to support that. From the supply side of things, the pediatric nephrology world actually opened up more fellowship positions in anticipation for their growing need, but for some reason these positions have remained vacant. So this past year, 43% of those fellowship spots were empty. And also, pediatric nephrologists are the oldest group of pediatric subspecialists. The mean age is 57 years old, and actually a third of those reported that they plan to retire by 2018. So a huge chunk of the workforce is going to be leaving. So from our perspective, in working with our pediatric nephrologists at UNC, we were thinking that one of the solutions which has been pretty popular in the pediatric world in dealing with the subspecialist shortage has been co-management. And what this idea of co-management is just a way to better use the existing workforce and the primary care providers as the initial point of care for these patients. And what that means in the kidney world is that these patients can hopefully receive more timely management, either before initial consultation or between appointments with their specialists. So one of the big questions we wanted to answer is, how are we supporting our primary care counterparts in dealing with this, and are we equipping them with the correct knowledge and resources to be successful in that role? So what we did is we just developed this survey along with the Gilling School of Global Public Health to really, almost in a quality improvement type of way, assess how UNC is communicating and collaborating from the pediatric nephrology side to the primary care providers, and really to focus on what areas of improvement we can focus on. So UNC's electronic medical record system is Epic, and Epic actually has a referral database embedded inside of it. We transferred over to Epic in April of 2014, so we really only had data points from that time, and we just sorted the data based on those who had referred to children's nephrology. Unfortunately, after the IRB went through, it turns out Epic can only provide us with the provider name and the office phone number, so then we had to chase that down, contacting each of the offices, getting their fax number and asking for the email addresses, but most offices actually did not have the provider's email address. So a lot of our communication actually happened through fax. We sent a fax and email recruitment message with a link to our online Qualtrics survey, and then just kind of bothered people for a week and hoped that they would respond. And unfortunately, based on the Epic database, there were lots of duplicates. 4 were military, so they said that they were not allowed to participate. And then 13 had confirmed contact failure. And what that means is the email address that we had did not work, like it bounced back, or the office refaxed us and said that provider no longer works here. So we ended up having a potential sample of 177 unique providers. And unfortunately, only 10 responded. So our response rate was only 5.6%. So of course, that was a huge limitation of the study. But some of the things that we were thinking about, a lot of times the provider never worked at, or no longer worked at that practice since the data was really outdated. We also think that fax-only invitation might not have been the best way since it's an online survey. And due to limitations with the IRB, our response window was actually only 1 week long. So also the providers didn't have a lot of time to turn over the survey. And we were unfunded, so we did not have incentives. So looking at our 10 responders, most of them were female, between 35 to 54, practiced in a suburban setting, and lived within, or worked within 25 miles of UNC, and most of them referred less than 5 patients to pediatric nephrology per year. So one of the questions that we really wanted to look at was what types of conditions do these primary care providers see in their practice? And this is the 13 top most referred conditions to pediatric nephrology. And as you can see, all of the providers saw hematuria, proteinuria, UTIs, and hypertension over the 6 months prior to completing the survey, and more infrequently, nephrotic syndrome and HSP. And so one of the things we wanted to look at is what is their initial comfort level in working up and managing these patients from their side of things. And in the conditions that they were most comfortable in were the ones that they saw most frequently, and obviously they were more uncomfortable with the conditions that they didn't see as frequently. And chronic kidney disease, as you can see, was the one that they reported being the most uncomfortable with managing. And this is showing where they lie on this. Oops, oh, wrong way, no, hold on. Okay, there we go. Some other points of information that I thought was interesting was that 30% reported dissatisfaction with the wait time for their patients to be seen by pediatric nephrology. And in terms of communication, 80% said that they would prefer to have clearer management plans in the consultation notes, and 80% also wanted to receive more information about the patient's diagnosis within those consultation notes. We also asked about continuing education opportunities, and 70% said that they were interested in these, and of those who were interested, 86% wanted more information about hematuria, proteinuria, hypertension, and acute GN. Something, since the way that we got this sample was through EPIC, we wanted to stratify the data to see whether or not EPIC access really made a difference. And although it was not statistically significant due to the sample size, this showed us that it does seem to be a difference, and that largely has to do with how we selected these people who responded. So in conclusion, our data was not statistically significant. It was just suggestive. But what it tells us is that we really need to provide primary care providers with more information about nephrology conditions, either in their consultation notes or through educational opportunities. And this is especially true for those who do not have EPIC access. And the diseases that we wanted to focus on are CKD, nephrotic syndrome, and autoimmune diseases. We are continuing the study, and this is because we didn't really seem to get a good sample size for those who are more geographically distant from UNC, or those who serve underserved communities, those with poor access or poor resources, because they probably are going to be more likely to rely on their PCP for management. To improve the response rate, we're going to try to cast a wider net, get AAP approval, and definitely have a larger response window this time. So.